Welcome everyone. Thanks for coming. I think you mostly know who I am, but my name is Brenman. I'm an exercise physiology student in the Farkas lab, and today I'm going to be discussing the impacts of obesity on health outcomes in chronic spinal cord injury. This presentation was developed based off of an analysis and manuscript I just finished, and it will be submitted for publication shortly. But I'm looking forward to sharing some of the findings with you today. So thanks for coming, and hello to maybe anyone on Zoom. Okay, so you should be aware that obesity has widely been considered a pandemic for some time now by the World Health Organization, and stems primarily from an energy imbalance. And what I mean by that is a mismatching of energy intake to the energy needs or expenditure of an individual. And this happens due to a variety of factors, both environmental, including things like lack of education or emphasis on a healthy diet, or lack of access to proper nutrition, as well as various psychosocial and genetic factors. And this is a really studied area because of primarily the health risks that are associated with obesity. And it's well documented that obesity is associated primarily with cardiovascular disease risk and cardiometabolic disease risk. And so what comes to mind first is diabetes, hypertension, and hyperlipidemia. But these risks extend further to other physical and psychosocial health outcomes like osteoarthritis, urinary tract infections, pressure injuries, and depression. And so BMI right now still remains the primary measure to identify obesity in the general population, measured by a simple ratio between height in kilograms and weight. Weight in kilograms and height in meters squared. You see the scale here that categorizes individuals based off of BMI. And on the left, you see a healthy weight category with a BMI corresponding of 18.5 up until 25. And then obesity starts at 30 and up. And while this is a worldwide health issue, it affects the United States uniquely with really high prevalence rates across the board. So here's a map that the CDC recently put out that's color-coded with prevalence rates of obesity. And so it doesn't take long to look at this map and see just how big of an issue this is, with the darker red colors corresponding with upwards of 40 and 45% obesity. Shout out to my home state of Rhode Island. That's too small to be seen on the map here. And in spinal cord injury, we see obesity as well. And we refer to this as neurogenic obesity, which was first introduced by Dr. Farkas and Dr. Gator, which encompasses the neurogenic components that spinal cord injuries experience post-injury. And this comes from motor paralysis leading to rapid and obligatory sublesional muscle loss. And when you couple that with the energy imbalance that people typically see, this leads to an accumulation of body fat. And so here's an image that compares healthy, uninjured, age and weight matched control on the top. And then on the bottom, you can see an incomplete spinal cord injury 6 weeks post-injury. And these are MRI cross-sections of the mid-thigh. You can see on the bottom the accumulation of subcutaneous and intramuscular fat here. In the literature, we see a really wide prevalence of obesity and spinal cord injury, anywhere from 22 to 97%. And this is due to a variety of measurements that are used to identify obesity in the population, whether that be using BMI or other accurate, adipose tissue measures like body fat percentage, or fat patterning measures like waist circumference. But overall, there hasn't really been a consensus of what the prevalence is in the population as a result of all these measures being reported. However, there's been a variety of reduced spinal cord injury specific cutoffs to identify obesity in the population. And one of them that have been widely adopted since 2009 is a reduced cutoff down to 22 kilograms per meter squared. And so the study that I'm going to be discussing today aimed at evaluating the prevalence and the health impacts associated with obesity when defined by the SCI specific threshold of 22, along with the general population threshold of 30. And the hypothesis here would be that spinal cord injured individuals identified by the BMI of over 22 would identify a greater proportion of the population, but still be associated with increased odds of adverse health outcomes. A secondary aim here was to assess these associations by neurological impairment category, to assess for differences in injury characteristics, with the hypothesis being here that more severe neurological impairment would be associated with stronger associations. And so all of this data came from spinal cord injury model systems, which, if you are unfamiliar, is a multi-centered program with centers across from the US that contribute to a database, and it tracks the long-term consequences of spinal cord injury through two long-form surveys. Form 1 and Form 2 is what they're called, with Form 1 completed at initial hospitalization date, and follow-ups at 1 year post-injury, 5 years, and every 5 years after. Surveys from Form 2 are completed. And so what this allows us to do is contribute to a very large data set with a diverse cohort. And for this study, all of the data that we obtained was taken from primarily the most recent follow-up, or if some non-modifiable variables like height or sex, race, ethnicity listed here were taken from the initial hospitalization time. Eligibility criteria were quite simple for this study. Inclusion consisted of 18 and up, and you had to be enrolled by October 1st, 2011. This is when height and weight was first recorded for everyone in the database. And this was, of course, necessary to then calculate BMI. Exclusion criteria was if you were missing this information, lost to follow-up, or missing some of the health measures of interest. And so I'm going to go through all of the variables that were used in the analysis here, and I'm going to provide a little bit of detail because some of them were modified slightly for the analysis. First, we did split up these variables into 3 health domains: cardiometabolic, physical, and psychosocial health outcomes, with cardiometabolic including those 3 metabolic diseases: diabetes, hypertension, and hyperlipidemia. And in the surveys, this is a simple yes or no question of the prevalence or presence of these diseases. This is the list of the physical health measures that were included. Arthritis included a variety of subcategories here, with osteo and rheumatoid arthritis, but also including gout, lupus, and fibromyalgia. Pressure injuries was defined as open or broken skin within the past 12 months, and this was a simple yes or no. Urinary tract infections had to require antibiotics, and it was within the past 12 months. We collapsed this into a binary variable, so it was 1 or more or none. Similarly, falls was collapsed to 1 or more or none. Sleep difficulties were defined as problems falling or staying asleep. This was also collapsed into a binary. A number of days rehospitalized was pretty straightforward here. And then pain severity was assessed through severity and pain interference, so 0 to 10 with a greater value indicating more severe pain. And then for interference, it's interference with various activities from 0 to 5 in the past 4 weeks. Self-perceived health status was health rated from 1 to 5, and this is a subjective self-reported measure. And in this case, a higher value indicated poor self-perceived health. And then lastly, we have a couple psychosocial health outcomes, with depression assessed through the patient health questionnaire. That's 9 questions that assess depressive symptoms. Depression was collapsed into having some depressive syndrome or none, with severity ranging from 0 to 27. Resiliency behaviors were assessed through the Spinal Cord Injury Quality of Life Survey and scaled from 0 to 100, with higher values indicating more resilient behaviors. And then here, life satisfaction was the sum of 5 different questions measuring life satisfaction. Looking a little bit at the data and analysis here, like I said, some of these variables were modified as just described to improve sample size. And there's going to be a lot of data that I present today. I'm going to walk through it slowly and try to highlight some of the differences and significant findings. but all the data will be presented as mean and standard deviation, or sample size and the proportions. And these tables that I present will be split into two separate analyses. One that assesses the 22 cutoff, and so there's two groups, one above BMI of 22, one below, and then a separate analysis using the BMI of 30. And we looked at group differences here with these tests for categorical and continuous variables. Associations were also assessed through logistic regressions, and I'll be presenting the odds and 95% confidence intervals here with some adjustments made. And then lastly, to address the AIM-2, which was neurological impairment adjustments, we stratified the cohort into three categories, including paraplegia with AIS categorizations of A, B, and C, and then tetraplegia, A, B, and C, with a third group of all AIS-D, which is the lowest injury severity in terms of neurological impairment. And then some multiple and logistic regression analyses were performed to look at these same associations between obesity and the health measures I just explained while accounting for neurological impairment. And an alpha of 0.05 was implemented here. So first and foremost, looking at the BMI distribution of the entire cohort, we ended up with 1,577 individuals. On the left, you can see each group's average and standard BMIs. And the histogram here shows, of course, the distribution with the red lines indicating each cutoff. And so first, I'll just point out that a BMI greater than 30 included 24% of the cohort. So this 30 cutoff is the general population identification of obesity, whereas the adopted SCI-specific criteria is above 22 and included 73% of the cohort. And so this is a 50% difference between these cutoffs, meaning the SCI-specific criteria identified nearly half of the cohort included in this definition. And when we compare this to the map that I just showed you, the prevalence of obesity in the US currently is about 40%. And so this is a 30% increase from what we would see in the general population. Lastly, I'll just say that this is among the largest cohorts that have been analyzed using the SCI-specific criteria and also looking at some of the associations with various health outcomes. What do you mean by relevance? Because I guess when it comes to the data that was obtained, it came straight from Form 1 and Form 2. And so all of the weight information was obtained from the initial hospitalization time. Well, I guess, when it comes to the general population weight categories, we see this having, changed over the past couple decades. Right? So that map that I showed you with the high prevalence rate, it's pretty universally seen, rates, right? And so what we see with spinal cord injury is, of course, this shift in body composition that occurs with the muscle loss and the additional accumulation of fat. And so this redistributes composition, and I think that's ultimately what leads to this high prevalence, right? But this is a difference that we see. So if we were to apply the general population cutoff here, we would actually see a reduction in obesity using the cutoff of 30, which kind of highlights maybe some of the issues here. And so comparing these two, we'll be able to kind of see some differences along other health measures as well. But I can show you first some of the demographic information that includes the weight for each category. I mean, in terms of shape, this is somewhat normally distributed, and I would anticipate a similar looking distribution in the general population. But this has shifted, right, towards the higher BMI scales over the past, I would say, 50 years, quite dramatically. Okay, so I'll just highlight some of the demographics for the cohort overall. This is what some of the tables will look like that I present today. And so they're split between the two analyses with two groups on either side, both above and below each BMI cutoff. And so just to focus in on some of these differences, we saw some differences when it comes to age, with the older group being above 22 and 30 BMI. Additionally, some differences with the 22 cutoff in gender. Of course, we see some in weight, with BMI being calculated with weight and height, and some differences in neurological categories here. Looking at some of the socio-demographics as well, we see some differences in marital status, employment, and family income. So turning to the first primary measure of interest, the cardiometabolic health outcomes. These were significant across the board, with greater prevalence of all three cardiometabolic diseases using either cutoff of 22 or 30. And then when you look down at the odds, we see an increased odds still while using this BMI of 22. And so I think what's important first to highlight is that a BMI of 22 in the general population would fall within a healthy weight category. But when we're applying this to spinal cord injury, we see nearly a twofold increase in some of these cardiometabolic risks. And these odds here are adjusted for some of those differences in the demographics, and it included age, gender, marital status, and level of injury adjustments. And so while this is, within a healthy BMI, 22, for the general population, we see some serious cardiometabolic health risks associated with individuals above this in spinal cord injury. And when looking at just the extreme BMIs over 30 for spinal cord injury, we do see some increased risk when it comes to diabetes and hypertension, with an odds ratio of 305 and 2.5 for diabetes and hypertension. We actually see a reduction in hyperlipidemia. And so yes. So you mean just between 22 and 30? Right. Mm-hmm. Yeah, I mean, right. I guess that would be interesting. This analysis doesn't encompass that, right? I mean, it really splits between the 22 and the 30 cutoff. However, there have been others that have suggested higher BMI cutoffs that might be appropriate for spinal cord injury, including BMIs of 25. And so I think what's shown here is that the reduction in the BMI cutoff to identify obesity still retains these risks that you would see with the more extreme group that you're referring to. What the cohort in between 22 and 30, I can't really answer that just from this. That would be a separate analysis, I think. What we did do is we broke this up between neurological impairment categories. And so I'm only going to be showing some of those significant findings in figures here, but all three cardiometabolic health outcomes are graphed here on the top. And then on the bottom, you see these three stratified groups with AISD, para-ABC, and tetra-ABC for each outcome. And then on the light gray bars, you see a higher prevalence across the board associated with a BMI over 22. And so what this shows here is that the risk is still there and higher prevalences when accounting for these individual neurological impairment categories. And in this case, we saw actually a greater proportion of individuals in each category with AISD, which is the lower level of neurological impairment category, which is somewhat contrary to what the hypothesis was. However, when we look at this with the BMI cutoff of 30, we see a very similar trend. Really, only difference here is seen in hyperlipidemia. But overall, we see nearly the same findings between the cutoffs. Very similar looking graphs here with greater prevalence in the light gray bars. Okay, and now looking to some of these other physical health characteristics and outcomes. First, some of the differences in prevalence. I'm going to help kind of zoom in on some of our different findings here. I know I'm showing a lot of data today. Main findings we saw that were different between these cutoffs started with arthritis. And so there was a greater prevalence of arthritis with a BMI greater than 22 and over 30. And this is in line with what we see in the general population, but I'll just remind you that arthritis encompasses both osteo and rheumatoid arthritis, along with gout, lupus, and fibromyalgia in the survey. Pressure injuries here was also different for the cutoff of 22, with a greater prevalence seen under 22. Typically, we would see what would be described as a U-shaped distribution in pressure injuries with more extreme weight categories, both experiencing higher rates of pressure injuries. But those of you that are in the field know that this is a pretty high prevalence across the board for individuals as a result of wheelchair use. And one of the explanations that's proposed here for lower BMIs experiencing higher prevalence would be malnutrition and poor wound healing. We also saw a similar difference here with urinary tract infections. And again, this is a pretty high prevalence across the board in spinal cord injury as it relates to bladder management and the use of catheters. And then lastly, in the bottom, we see differences when it comes to self-perceived health status. And in this case, a higher value indicates poor self-perceived health status. And so the greater BMIs above 22 and above 30 were both associated with poor self-perceived health reporting. Though these differences you can see are not that large, we see some differences when we now make some adjustments and look at odds. In reality, we just saw arthritis and self-perceived health status remain significant when making some adjustments. And so looking at arthritis, the odds were significant only for the BMI over 30 group. And that could potentially just be a result of greater body weights resulting in greater joint stress and potentially additional systemic inflammation impacting all of these diseases under this umbrella of arthritis. And then on the bottom here, we do see a difference when it comes to a BMI over 30. And so that would indicate a higher risk of poor self-perceived health status with the more extreme BMIs. And so arthritis was then graphed because we did find some differences when looking at the neurological impairment categories here. Again, with some differences in the AISD group and Tetra ABC. And this isn't so surprising because with the AISD, you see a more ambulatory cohort. And as a result, they might experience more joint stress. And so the light bar, of course, above 22. And similar results here with the BMI cutoff of 30. Right. And, it's a pretty broad grouping of diseases under arthritis. And so we think that might be one of the explanations here. And then lastly, the last health domain that was of interest was psychosocial health outcomes. And these were some interesting results. So we didn't see some of the traditional associations you would typically see in the general population, with greater BMIs and obesity being associated with depression and maybe life satisfaction. We did see some differences in the resilience behaviors, but what this suggests to me is that across the board, individuals with spinal cord injury might experience a mental burden that's unique to spinal cord injury. And similar here, with the life resilience scores, they're different, but they weren't that drastically different between both cutoffs above and below 30 BMI here. And so to kind of summarize some of these findings, first of all, a 73% prevalence of obesity is 30% higher than what you would see in the general population using this cutoff. With a BMI of 22, like I said before, fitting within a healthy category, but yet still being associated with all of this increased risk of cardiometabolic outcomes in particular. 49% of the individuals, if applying the BMI cutoff of 30, are missed, right, by using this general population criteria. And only encapsulated 24% of this cohort. With both criteria, as I mentioned, showing increased risk of cardiometabolic diseases. And so we would kind of expect the more extreme BMIs to be associated with maybe poor health outcomes when compared to such a reduction in the BMI criteria, but the only associations we saw that were significantly different between these were additional associations exposed with the 30 cutoff in arthritis and poor self-perceived health status. And then, like I just reviewed, some of these associations that you might expect to see in the general population with obesity and psychosocial outcomes were just not seen. And so potentially impacted by some other contextual or environmental factors as well. Yeah. Yeah, so age absolutely plays a role. However, you know, that statement is primarily tied to the odds ratios, which are adjusted for age, right? So those are kind of accounted within and adjusted for within the analysis here. However, there are some limitations to this analysis, and so I'm going to highlight some of them here. First, this is all self-reported data, right? And so there's inherent bias that's associated with these types of responses. I think arthritis is a really good example of how some of the specificity of these variables is, you know, broad, and if we kind of highlighted some of the individual health characteristics, maybe we would expose some other associations that we didn't see. And then we're missing some confounding factors that might play a role in modifying and, you know, changing these relationships, things like diet, physical activity, and smoking. And then lastly, this is using BMI, right, which is just a simple ratio between height and weight. There's other metrics and measures that might also associate with these health outcomes, something like body fat percentage, which we regularly obtain from DEXA scans. And so in conclusion, first, we see these similar risks. And what this, you know, supports is the use of 22 as an appropriate cutoff for spinal cord injury. And it also highlights the dangers of just using the traditional general population cutoff of 30, because it doesn't include almost half of the population, right? So it misses almost 50% if you're just using the general population that would otherwise be considered obese. We might opt for some other measurements of adiposity to identify risk outside of BMI. However, the adoption of this SCI-specific criteria, the BMI over 22, is important for a couple reasons. So first of all, we have to establish a consensus, a wide consensus, and have people use and utilize this threshold to identify these risks. Education and promotion of some of the alternative measurements is important as to not fall into the dangers of just generally applying the 30 cutoff. And then lastly, this can advance some of our risk assessments and properly identify the people at risk so they can be maybe eligible for targeted interventions going forward. All right, thank you. Yes. Do you want to take a look? So I can tell you right away that, here we go. They were predominantly more male in the BMI over 22 group, whereas when cut by the BMI of 30, we didn't see any differences here.
Individual with obesity and neuropathic pain in that individual?
Neuropathic pain. So, when it comes to the pain variables that we highlighted here, we looked at severity and interference. And from what I'm aware, the survey is quite broad in terms of the definition of pain and what they experience. And so those are self-reported measures and doesn't kind of distinguish between the types of pain. So I couldn't answer that with just these results, but some of the people in this room could.
Bad has your pain been in the past 3 weeks or something like that? 4 weeks maybe, I can't remember. How bad has it been and how much does it interfere with everything? So, but now we've implemented a better, more specific look that can determine neuropathic or probably neuropathic versus probably not neuropathic. So anyway, not available for this analysis. No, it's just yes or no. There are some, there's a list of questions.
No change, right?
What do you mean? Oh,
We didn't find a significant differences
Right.
between the pain, which could suggest maybe that people have pain from various causes and not just tied to arthritis and maybe a high prevalence in both cohorts.
Thing that Dr. Felix brought up earlier about that cohort between 22 and 30, it would be interesting to look at. But something we were discussing this morning is the Lofton paper from 2009 that originally established the 22 cutoff had never been validated. So we do not actually know if this is the correct value. So there are other papers out there from various groups, soon to hopefully be us, that are going to try to validate this number and see if we can reproduce what they are showing. Because Jesse was saying earlier, there's some papers that report 23, some report 25, and we see the same sort of phenomenon occur with custom waist circumference for spinal cord. So, it very well might be that, 22 is too low, or maybe it needs to be, the actual paper is 22.1, but nobody actually uses that. The other thing that's really important that's not actually captured is the injury level, right? So we know from published literature that persons with tested routinely present with more body fat and less lean mass and paraplegia. So is 22 appropriate to use for both populations? So I think part of the reason that 22, like Dr. Nash, recommended this as the enforcement guidelines is because that is the only paper that was done in North America that provides a different cutoff than is currently used in the general population.
Right. I mean, I think it's known that we could use some other measures to more accurately kind of pinpoint what the risks are associated with heavy body weights, but BMI not going anywhere. So ideally, we can narrow down the more, the most proper, cutoff to use clinically. Yeah.
Between males and females, do you think that's actually reflective of the population, or do you think that could be really a limitation of using BMI or using the same cutoffs for males and females?
Yeah, I mean, definitely, gender differences is something that BMI can't account for. Right? It's really just using height and weight, and so it's not sensitive to gender specifically, but spinal cord injury is more prevalent in males overall. Why we see this difference, it's not dramatically different between groups here, but there's absolutely like an inherent flaw here with using BMI. However, like I said, not only is it not going anywhere, but as you increase sample size, BMI actually, does a better and better job at, looking at associations with obesity, just because the traditional knock on BMI is that, well, you can have a lot of muscle tissue or high lean mass and still be defined as obese, whereas someone could have the same height and weight, but a very different body composition. And so realistically, as we kind of zoom out and include more people in a cohort, there's not that many people that fall into that category where they're essentially so jacked and have so much muscle that they're improperly identified as obese, right? Yes.
Aspects of sort of feeding and how they might be contributing to obesity. Specifically, not that I'm proposing this is the case, but like after, like if somebody has tetraplegia, like they cannot, necessarily, feed themselves versus those who could, versus, whether any other sort of behavioral sort of contribution to the effect.
Right. Well, I think when it comes to this analysis, there's only so many of the variables that were included. But I don't think that Form 1 and Form 2 includes a lot of eating behavior, questions, or none, right? And so maybe that's a future direction for model systems here.
In mind that we're trying to get a breadth. We can't, unfortunately, that's the limitation, right? We can't have people answering questions for 5 hours. So it's always a limitation, unfortunately.
I would say the one variable or two variables that are looked at in Form 2 that kind of address that is part of the chart variables asked about assistance and types of assistance, paid versus unpaid, and that is specifically addressing paid activities again and their point.
Right.
So maybe perhaps that could be another question about this future BMI associated, and also relating level of injury and ALS still, if that, to what extent does that impact the amount of assistance that is required in a 24-hour period?
Yeah, absolutely. It's definitely like one of the biggest confounding factors when it comes to weight gain, right? Is eating patterns, eating behaviors, and so that's going to be a focus, of the lab overall going forward too.
An occupational bias, so yeah, pushing this
But there is that's a good point, Heather. There is a question that specifically asks about the amount of it is self-report again, but like, just,
In terms of
you
things like self-eating.
You didn't throw that into the analysis.
Right.
I mean, it's a probe. We could
So we
see.
actually got that data, but I think when we were planning the study, you guys basically said it's not a very useful tool and you're not really good about it.
But for that one question,
Yeah, well,
we were talking about anyway.
maybe if the reviewer asks for that, I'm not good at the rules of that.
Right.
So I mean, as a probe, like to see for future research, like just to see if there's anything there. Anyway.
Yes.
Are there any studies looking at GLP-1 agonists in people's spinal fluid or maybe the possible benefit?
There's actually now 2 case series. Bill Bauman's group, originally had some VA funding for COVID, here. So it's a 4-person case series. One that's the intervention group, one that's control, and it works. They show positive effects with fat loss, but you also, I always constantly saying, but remember sometimes that the lean mass is also lost, right? And everybody loses lean mass on these drugs. You lose lean mass regardless of dietary intervention or exercise intervention, but these people are already starting out with lower thresholds to begin with. So the proportion of NAC that they're losing is already greater. So these are lifelong drugs that they have to stay on, and if they're expensive, side effects are horrible, but they do have positive effects, but in a way that's compared to
What the side effects of people with spinal greater than people in the normal
not that they're greater, but for example, there's a lot of GI-related side effects. So you're already in a population but it's susceptible to GI-based issues. So it's a drug that amplifies that. So the drugs subside to the side effects, but it's getting through that is really the hardest part. There was recently tirzepatide, which were the later ones, was recently studied in somebody with SCI, single case report, good results. But again, I don't think they used that in that study. The other one did. But there's been a lot of new drugs that have been currently being developed for obesity that reduce the number of side effects. As the science advances, they're minimized, but I don't think they would minimize the big component of building mass loss. That's extremely important because ultimately that's determining the pathways and energy requirements. And they already, both SCI already have to do appetite, right? So you're not sensing hunger. They sort of sense fullness, but we don't think it's really a true sense of fullness. And I don't think it's going to be a long-term fix. And effective drugs, maybe honest with it, but right now they're very supply.
Right now on clinicaltrials.gov, there's one study with these outcomes, GLP-1R agonist therapy. There's 2 right now recruiting for spinal cord injury with GLP-1s, but the other one has bone outcomes. So it's in San Antonio, Texas. Gary, I don't know if you know who that is.
Who's the contact on the?
Let me look. Texas Diabetic Institute. Salea is the last name of the MD. Anyways, yeah. We got one lead.